Every health system faces the same uncomfortable problem. Resources are limited. Needs are unlimited. Governments must decide which diseases to prioritise, which treatments to fund, and which programmes to delay or abandon. But to make those decisions, policymakers need a way to compare very different kinds of suffering. How should we compare blindness with cancer or depression with malaria? Over the past 30 years, health economists have tried to answer this question using two powerful metrics: the Quality Adjusted Life Year, or QALY, and the Disability Adjusted Life Year, or DALY. Both attempt to convert human health into numbers, but they do so in very different ways. At first glance, measuring health seems simple. A treatment either saves lives or it does not. But modern medicine rarely works like that. Many treatments do not simply extend life, they change the quality of life. A hip replacement may not extend life at all, but it may transform someone's mobility and independence. Mental health treatment may not change mortality, but it may radically improve daily functioning. Health economists therefore needed a way to measure both length of life and quality of life together. That challenge led to the development of the QALY. A QALY measures health gain. 1 year of life in perfect health is counted as one QALY. If health is less than perfect, that year is given a value between 0 and 1. For example, a year lived with moderate illness might be valued at 0.6. So if a treatment gives someone 10 additional years at a quality of 0.6, the treatment produces 6 QALYs. This simple idea became extremely influential. In the United Kingdom, organisations such as the National Institute for Health and Care Excellence use QALYs when deciding whether new treatments provide sufficient value for money. The QALY therefore became a tool for evaluating health improvements. But a different problem soon emerged. How do we measure the burden of disease itself? In the early 1990s, researchers working with the World Bank and the World Health Organization wanted to compare the burden of disease across the entire world. This required a measure that could combine two things: years of life lost due to premature death, and years lived with disability. The result was the Disability Adjusted Life Year. A DALY measures health loss, not health gain. One DALY represents one lost year of healthy life. If a disease causes early death or prolonged disability, it generates more DALYs. Using this method, researchers were able to rank diseases globally, and the results were sometimes surprising. Conditions such as depression, back pain, and mental illness appeared far more significant than previously recognized. Although they look similar, DALYs and QALYs were designed for different purposes. QALYs were developed primarily for clinical and economic evaluation, particularly in high-income health systems. DALYs were designed for population-level comparisons, especially in global health. In simple terms, QALYs measure health gained through treatment. DALYs measure health lost through disease. This difference means that the two measures are often used in different policy contexts, but the story is not quite so straightforward. The original DALY model contained several assumptions that later became controversial. One of these was age weighting. In early DALY calculations, years lived by young adults were sometimes valued more highly than years lived at very young or very old ages. Another assumption was discounting, meaning that future health was treated as slightly less valuable than health experienced today. Finally, disability weights were assigned to different health conditions, often based on expert judgment. These assumptions allowed researchers to construct a single global metric. Another criticism concerns the relationship between population metrics and individual experience. DALYs operate at the level of populations, not patients. They estimate average disability weights for conditions such as blindness, deafness, or chronic pain, but any clinician knows that individual patients experience illness in very different ways. Two people with the same diagnosis may report very different quality of life. This raises an important limitation. DALYs help policymakers understand patterns of disease across societies, but they cannot fully capture the lived experience of individual patients. Despite these criticisms, both DALYs and QALYs remain extremely influential. They provide a way to move beyond anecdote and emotion when allocating scarce resources. Without such measures, decisions might depend entirely on political pressure or media attention. Instead, these metrics allow policymakers to compare interventions systematically. Vaccination programs, cancer treatments, mental health services, and prevention strategies can all be evaluated using a common framework. In practice, many health economists now see DALYs and QALYs as complementary rather than competing measures. DALYs help us understand the burden of disease in populations. QALYs help us evaluate the benefits of interventions. Yet one final question remains: can human suffering really be reduced to numbers? DALYs and QALYs are powerful tools, but they are ultimately simplifications. They help governments see patterns across millions of lives, but they should never replace the moral judgment required when caring for individual patients. In the end, these metrics do not make decisions for us. They simply help us see the choices more clearly.